In Chapter 23, we will be going over general medical conditions and additional health concerns. As far as medical conditions and athletics, athletic trainers are often the first to recognize medical illnesses due to our proximity to athletes. So either because we recognize them without the person telling us, or because the athlete will come to us and ask us or tell us they're feeling sick and ask us how we can help. Skin conditions are prevalent in athletes who have a lot of close contact, for example, with water polo and wrestling and possibly rugby. And those can be passed easily by sharing equipment. So we want to try to avoid having people sharing equipment, preferably. Athletes shouldn't participate when they have an infectious illness or an outbreak due to the risk of infecting the whole team. Even teammates who don't spend a lot of time together outside of sport can pass medical illnesses to each other just from being in close proximity while playing their sport. The first medical condition we'll go over is a skin infection called herpes. So herpes is a viral infection that tends to occur in or near mucous membranes. So say, for instance, on the mouth here, that's a herpes infection. We have two different kinds of herpes. We have type 1, which would produce a cold sore, and then we also have type 2, which is considered genital herpes. Technically, you could have type 1 herpes on your genitals and type 2 herpes on your mouth. I'll let you guys figure that one out yourselves. But generally speaking, that's kind of how we classify them, as type 1 and type 2. There's also another type of herpes called herpes zoster. This is also known as shingles. And shingles is extremely painful, but it's a reappearance of the chickenpox virus. This is most common in elderly people, so there is actually a shingles vaccine, but most people can't get it until they're, I believe, 55. However, people can actually contract shingles before that. It's just not nearly as common. Basically what happens is this herpes zoster is a reappearance of the chickenpox virus. So this will happen in people who've either had chickenpox or had a chickenpox vaccine possibly. And you get these blistering type sores in a specific pattern on the body. So this is usually following a specific nerve root from like the spinal cord. And we can get it anywhere, but it's particularly dangerous on the face if it's near the eye. So that will be followed more closely, but oftentimes it will be also on the torso. This is just extremely painful, and it takes a long time to get over. Signs of herpes is you'd have an early indication of tingling or hypersensitivity in the affected area about 24 hours prior to the appearance of lesions, then local swelling followed by an outbreak of vesicles or little blister-like sores. The sore will generally heal in 10 to 14 days. Since this is a virus, when somebody has it, they have it for life. It's just a matter of when they get outbreaks. They're more contagious when they are getting an outbreak. As far as care, if an athlete has an outbreak, they should be disqualified from competition due to the contagious nature of the condition. So especially if they're having close contact with people. If somebody has herpes on their mouth, it's probably not a huge deal for them to play in a soccer game. They shouldn't be getting touched in the face by another player anyways. But if somebody plays water polo and they have herpes on their mouth, that is an issue. We want to utilize universal precautions when dealing with the herpes virus. We don't want to pass that to ourselves. And somebody with herpes can use antiviral drugs to reduce the risk of reoccurrence and shorten the course of the outbreak. As far as another skin condition that is a virus, we will talk about verruca virus or warts. There are there are several different types of warts. They're all viral infections. So we could have a verruca plana, or a flat wart, a verruca plantaris, or a plantar wart, so that would be on the bottom of the foot, or the plantar surface of the foot, and a condyloma acuminatum, I think I'm saying that correctly, which would be a venereal wart, so that would be an STD. There are different types of HPV, or human papillomavirus, which is what causes warts. And basically that virus uses the epidermal layer, or the top layer of the skin, to reproduce and grow. So when it's growing, you get these lesions or bumps known as warts. The wart virus will enter through a lesion in the skin. So it could be something as small as a hangnail or a paper cut or an abrasion, possibly. So these can easily, the virus here can easily enter your body. Signs of the condition would be a small, round, elevated lesion with rough, dry surfaces that can be painful when pressure is applied. With the warts, we have a couple of different concerns. First of all, they're infectious. We don't want to pass them. Second of all, they can actually get ripped off and cause an open wound. And third of all, they could be subject to a secondary bacterial infection as well. So it's ideal to try to heal these up. Care for warts would be if it's vulnerable, so if it's a big bumpy wart like in the picture here, and the individual is using their hands in sports, like say for instance football or something, we'd probably want to cover that up so that it doesn't get ripped off. And then it can be treated by a physician later on. The physician can either burn it off or freeze it off. So they can use electrocautery, so they can use electricity to burn it off, topical acid, salicylic acid, or liquid nitrogen, which will freeze it off. Those are the most common ways of managing warts. They can also be basically cut out with a scalpel as well. Another type of skin infection that we could get would be bacterial skin infection. There are two types of bacteria that may be involved when we're talking about skin infections, either Staphylococcus or Streptococcus. And these two are different types of bacteria. We have three different types of bacterial skin infections that we'll talk about here. This is not an exhaustive list, there could be more, but these are common in sports. The first is impetigo contagiosa. This is called by a streptococci bacteria, and this is spread through close contact. So this wound right here, that's an impetigo rash. This is common in wrestling, possibly could be spread in water polo, but little kids can get impetigo as well. It's commonly spread through preschools. Another type of common bacterial infection would be a furuncle, also known as a boil. So this would be an example of a boil. It's kind of like a giant pimple that doesn't come to a head. These are usually a result of some kind of staph infection. There's an infection of the hair follicle that results in a pustule formation. Oftentimes with a boil, the pus doesn't work its way out of the skin like a pimple, though it will work its way into the skin and cause a really raised up red, angry sore. These can become very large and painful. We don't want to try to drain these ourselves, but if they're becoming very painful, we could go to see our doctor and they could take care of it. Another type of bacterial infection would be folliculitis. So this is an infection of the hair follicles, and it's most commonly around the face and neck or in the groin, oftentimes from shaving with a razor that has a bacteria on it. This is a really good reason not to share razors with people. Symptoms of bacterial infections will be mild itching and soreness, followed by an eruption of small pustules that rupture and crust. They're going to exhibit signs of inflammation like tenderness, warmth, redness, and swelling. We want to take care of these by making sure they stay clean and using a topical antibacterial agent like triple antibiotics, say for instance. For that huge boil, that's probably not going to be super helpful. The person may need to be on a systemic antibiotic, so an antibiotic pill. Pus-filled lesions should be drained by a doctor, and we want to minimize the chances of infections being spread to others. So we want to cover impetigo before we let our child go to preschool, say for instance. We want to make sure that somebody who has folliculitis all over their face isn't wrestling against another athlete at that time. So we just want to make sure that we're not spreading these bacterial infections around. A special type of staph infection that people can get is called methicillin-resistant Staphylococcus aureus, so otherwise known as MRSA or MRSA. This is a particularly nasty staph virus, although it's become so commonly recognized that it's actually treated more efficiently and more effectively, and it's becoming less of an issue than it was maybe, say, 10 years ago. The cause of a MRSA infection would be that MRSA is a strain of bacteria that is resistant to methicillin and other antibiotics. So say for instance, I don't remember exactly off the top of my head how many antibiotics there are in the world, but say for instance if there were 100 different types of antibiotics, MRSA might be resistant to 20 to 30 of them. So it's not that antibiotics don't work on this, it's just a lot of commonly used antibiotics don't work on it. Originally, MRSA started off in hospital patients. We called it a nosocomial infection that originated in the hospital, but then it slowly spread to becoming a more community-wide infection as well. So generally speaking, when MRSA first started, it would occur in patients in the hospital who were already ill. So they would often have open wounds and bed sores or burns and get these skin infections. Sometimes people in hospitals can get MRSA-related pneumonia also, so they can inhale it. But this has spread to be more of a community-wide disease, like I said, that can affect other people too. Most people, as far as symptoms, most people will look at this little sore and think, oh my gosh, I got a bug bite. That's a spider bite. And they'll go to the hospital and they'll say, I got a spider bite and it's pretty tender and it's sore. And my husband cracks up about this. He's a physician assistant in the ER. The running joke in the ER is that it's never a spider bite. It's pretty much always MRSA. So, but that's what people think, is they think they got bit by a spider. But then they'll get a broad range of symptoms that progress quickly. So it'll start off with this little tiny spider bite-looking thing. It's red and tender and slightly swollen, and it will quickly get larger. The other thing that's important, to note is that you can carry MRSA without having symptoms. Most hospital workers actually do carry MRSA in their nasal passages, but they don't get sick. So they carry the bacteria, but then they aren't infected with the bacteria. There's a difference between having bacteria on you and becoming infected. All of us have bacteria on us. We all have bacteria on our hands, in our mouths, other places, but it's not until those bacteria become out of control that we accrue an infection. As far as care of MRSA, this can require much heavier doses of antibiotics, and some infections can only be treated with IV antibiotics, which would require several weeks of treatment. If we let a MRSA infection go too long, the person can lose very large portions of soft tissue and even possibly lose a limb. So, you want to make sure that you're able to identify this, or at least say, oh, that little thing that started off as a bug bite got really big really fast. You should probably go to the doctor. But most of the time now, in recent times, that this is dealt with well at the hospital. The next type of skin infection we're going to talk about is fungal infections. The cause of this condition is the ringworm fungus, also known as tinea. So on this slide we have tinea of the groin and tinea of the foot. You can get tinea elsewhere as well, called tinea corporis. It's ringworm on the body somewhere else. And this is what a ringworm rash looks like down here. It will start off kind of maybe as some like little raised red bumps, and then it tends to spread into this ring of a rash. It's not actually caused by a ring, it's caused by a fungus, but it kind of looks like a worm that's spread out or something, I guess. That's why they call it ringworm. But it always has that ring-shaped appearance if it's on the body somewhere else. The ringworm fungus is the cause of most skin, nail, and hair fungal infections. So we do have two specialized areas people can get this fungal infection. So we have tinea of the groin, or tinea crurus, and tinea pedis, or athlete's foot. So these signs and symptoms of tinea crurus is that the person's going to have mild to moderate itching in their groin area, and it will be found bilaterally. So they're going to have the mild to moderate itching on both sides. They could have a brownish or reddish lesion resembling the outline of a butterfly on the groin. So if you look at both sides together, it looks like a butterfly. Care would be, we want to make sure we're treating this until it's cured to make sure it doesn't keep coming back. And tinea crurus will respond to many non-prescription medications like Tinactin or Lotrimin or things like that. Some of these will work faster than others. I believe Tinactin is supposed to work within 14 days and Lotrimin's a little faster. And there's some others on the market as well that are a little faster. If somebody has a failure to respond to these over-the-counter medications, it may suggest that it's not a fungal infection, like it could be possibly a bacterial infection instead, and the person should go to the doctor. Sometimes if somebody does have a fungal infection that's not responding to over-the-counter medications, then they may need additional topical medications and oral prescriptions. As far as athlete's foot is concerned, the cause of this condition is our most common form of superficial fungal infection. The webbing of the toes and the webbing and the top of the toes become infected through here. That's really uncomfortable and itchy. But the webbing of the toes become infected by a combination of yeast and dermaphytes. Signs here are extreme itching on the soles of the feet and between the toes and top of the toes. They'll have dry, scaly patching. You can kind of see that white patching coming through here if you look on that part of the foot. And red plaques, you can see the redness between their toes, forming larger inflammatory red papules, forming larger plaques. These people can develop a secondary infection from itching and bacteria, so if somebody's scratching this a lot, they can get a secondary infection. Topical antifungal agents like Tinactin or Lotrimin are usually pretty helpful here, and keeping good foot hygiene. So good foot hygiene would mean trying to keep the foot as clean and dry as possible. So sometimes when people have athlete's foot or they're prone to it, they need to change their socks multiple times a day. So they should wear clean, dry, white socks as much as they can throughout the day. They also should not be walking around the house barefoot because you don't want to pass it to other people. And they should be cleaning out the shower after they use it to make sure that they're not passing it to other people in the household. So again, just, nobody wants a fungus, so don't pass it along. But these are pretty easy to care for. Most of the time they're going to respond to over-the-counter medications. The biggest thing is making sure that you don't give yourself a secondary infection. The next illness we will be discussing is a respiratory condition called exercise-induced asthma. All of you in this class will probably at some point come across somebody who has exercise-induced asthma that you're working with, so it's important to be aware of what it is. So the cause of this condition is that it's an asthma attack brought on by exercise, but the exact cause is not known. We don't really know why exercise causes these asthma attacks. Some theories are that there's a loss of heat and water when an athlete starts breathing hard, especially in cooler weather, and that causes an airway reaction. Another thing that can cause some issues is eating certain foods. So if people are sensitive or allergic to foods and they eat them, that could cause a problem. Also, if somebody has been eating a lot of dairy, that can cause a problem as well because dairy can increase mucus production in the body. And sinusitis or having a cold could also be a trigger. Signs of condition, basically the person has airway narrowing due to spasm and excess mucus production. So if we look at this photo up here in the upper corner, this is a normal bronchiole. So that's a normal air pathway within the lungs. It's a tunnel basically. The outer lining is nice and thin. There's a big wide open space in the middle for air to run through. It's really easy to breathe through that. When somebody is having an exercise-induced asthma attack, that lining gets really swollen and irritated and uneven. So now the air going through that tunnel is, and not only is that tunnel smaller, but now the air coming through that tunnel is coming through a tunnel that is causing a lot of turbulence with the air. The other thing with asthma is that we're going to get this mucus production by the lining of the bronchiole that will narrow the airway even more. So now instead of the air being able to go through a tube this big, it gets to go through a small space that big. So when somebody's having an asthma attack, they will feel that their chest gets tighter. They'll have breathlessness or difficulty catching their breath, coughing, wheezing, nausea, hypertension or high blood pressure, fatigue, headache, and possibly redness of the skin. The wheezing usually isn't during the running or the physical activity. It's usually afterwards, actually. Care here would be getting regular exercise, using an appropriate warm-up and cool-down with graduated intensity, and possibly using an inhaled bronchodilator, so something like this albuterol inhaler. If a doctor has prescribed one of those, an athlete or a client should always have that with them available in case they need it. It's helpful to exercise in a warm, humid environment instead of a colder environment. If somebody is having a really hard time breathing, sometimes I'll actually, and it's cold outside, sometimes I'll actually have them even just cover their mouth and breathe into their hands, because that helps to warm up the air that's being exchanged with the lungs. And again, coaches or athletic trainers or personal trainers should remind athletes and clients to have their inhaler with them at all times, so somewhere that it's easily accessible in case they need it. Another type of issue that we'll all run into either ourselves or with clients or patients at some point is a gastrointestinal condition known as gastroenteritis. So sometimes we also call this food poisoning. Cause of the condition, we could have mild food poisoning to severe food poisoning. It just depends. But this is caused by infectious microorganisms that contaminate food, particularly during warm weather and periods of improper refrigeration. So this is common after eating food that was left out, like at a party or at a picnic. But we can also get gastroenteritis from improper food handling at a restaurant, or if a family member or ourselves, if we're not washing our hands appropriately prior to handling food and keeping food refrigerated. Signs of the condition would be nausea, vomiting, cramps, diarrhea, and anorexia. And here anorexia means that you don't want to eat. Usually gastroenteritis will subside within 3 to 6 hours. It's also normally caused by a staph infection. If somebody's having an illness that's lasting a lot longer than this, they probably have a different kind of infection. Care here would be rapid replacement of fluids lost. Sometimes it can be really hard for people to keep water down, so trying to keep something like diluted Gatorade down is sometimes easier, and if people can't even keep that down, sometimes eating ice chips is helpful. We want to have the person on bed rest in all but mild cases, and nothing should be given by mouth if vomiting and nausea persist. Again, ice chips are usually tolerated okay, but we definitely don't want to be giving somebody food or a lot to drink when they're vomiting. my son was sick recently, and I literally just gave him a couple sips of water after he'd vomited to try to rinse his mouth out, and he immediately vomited the water up. So even water can be a little bit tough when somebody's actively vomiting. Once somebody's feeling better, we want to reintroduce food that is easy on the stomach first. So things like white rice or dry toast with no butter, or bananas or applesauce, something like that. We don't want to, even if the person's hungry, we don't want to give them, like French fries and a cheeseburger or something right away. That their stomach is probably too upset to handle that. If somebody's vomiting for more than a couple of hours, they should probably go see their doctor. Another common gastrointestinal condition is diarrhea. As far as cause of the condition, diarrhea could be acute or chronic. It could be caused by lots of different things. It could be caused by a problem in the diet, or an inflammation of the intestinal lining, or a gastrointestinal infection, ingestion of certain drugs, and psychogenic factors. So sometimes when people get really stressed out, they can give themselves diarrhea if they're prone to that already. Signs here would be abnormal loose stool or passage of fluid, unformed stool. The person's going to have abdominal cramps, possibly nausea and or vomiting, and frequent elimination of stool. People can get extremely weak with having diarrhea due to dehydration. So you want to make sure that people who have diarrhea are hydrating properly. As far as care, we want to try to determine the cause if we can. Try to figure out if it's an infection or just an irritant or emotional upset. Athletic trainers can treat less severe cases by having people eat carefully and utilizing over-the-counter medications. Imodium and Pepto-Bismol technically work well. Usually I try to avoid medications like that if I have vomiting or diarrhea, just because I feel like if I have vomiting or diarrhea, my body's trying to rid itself of something, so I try not to stop it up. However, having said that, like if I had, horrible diarrhea and I had to go get on a plane and sit on a plane for 3 hours, I would definitely take some medication. We want to have the athlete consume bland food that does not irritate the system. So usually that would mean following the BRAT diet. So BRAT stands for bananas, rice, applesauce, and dry toast. That's generally recommended, but other things that are easier on the stomach like that as well could be helpful. So something like maybe pears might be okay, or plain pasta or something like that. That's something that's easily digestible. And again, we want that person to continue to hydrate, possibly with Pedialyte or dilute Gatorade as needed. The next illness we're going to talk about is infectious mononucleosis. Mononucleosis is a virus that has an incubation period of 4 to 6 weeks. What that means is that the person is sick for 4 to 6 weeks before they show signs of being sick. So this is another good reason not to share drinks or water bottles with people. This illness is passed through saliva most commonly, and what will happen as far as signs and symptoms is the first 3 to 5 days, so a little less than a week, the person will have severe fatigue, headache, loss of appetite, and myalgia, which is muscle pain. On days 5 through 15, the person can get a fever, swollen lymph nodes, and a sore throat, and about 50% will also experience an enlarged spleen. So basically what happens is the spleen goes from being this size to being much, much bigger here. And when we talk about swollen lymph nodes and a sore throat, this would be an extreme example of the tonsils being swollen. And the lymph nodes that are usually swollen are actually, they call them the posterior chain lymph nodes, They are on the lateral side of either side of the neck, on the lateral side, kind of a little bit posterior, and it'll feel almost like the person has a little row of marbles running down the side of their neck. And I've had student athletes who are actually so swollen that their neck actually looks swollen. I had a student athlete who came in and was complaining of neck pain, and he couldn't figure out what was going on. And when I started really looking at him carefully, and I did check his lymph nodes because he was so swollen, and I started asking him about, feeling sick or whatever else, and I truly think he had mono. I know they ran the test on him at student health, and it was inconclusive, but he was definitely showing signs of mono at that time. People can get jaundice from this sometimes. They can get a skin rash and puffy eyelids as well. The main symptom with this, generally speaking, is fatigue, but people can have any or none of these symptoms when they have mononucleosis. I had mono my senior year of college, and I was taking, I guess it would have added up to about 18 units of classes and working 30 to 35 hours a week, and I was exhausted, and to me that made sense because I was working so much and taking class so much, but I was downing coffee at like 10 o'clock at night during my EMT class, and then I got sick, and I actually ended up getting bronchitis, but it was a secondary infection to having mono, and the only reason I actually even ended up getting tested for mono is because two of my student athletes used to come in and use my phone all the time in the athletic training room. Told me that they were diagnosed with it, so I got tested just to see if that's what I had, and it turns out I did. As far as care, we want to do supportive symptomatic treatment. So if somebody's tired, they should rest. If they have muscle pain, then they should take some Tylenol. Or if they have a fever, they should take some Tylenol. If a person does not have an enlarged spleen, they can resume training after 3 weeks. And as long as they don't have an enlarged spleen, they do not have a fever, their liver function is normal, and they don't have a sore throat. So those are the main things. They may still be a little tired sometimes, but basically the biggest thing we're looking for is to make sure that their spleen is not enlarged. Again, this is a good reason not to share water bottles. If somebody has mono and they're playing with an enlarged spleen, it's very easy for their spleen to rupture, which is a medical emergency because the spleen makes red blood cells, so they can have a lot of bleeding and a lot of internal bleeding by rupturing that spleen. This last spring, I was working a lacrosse event, and there was a student athlete who came over and said that he wasn't feeling well and his stomach hurt, and we were trying to reason out what was going on, and we asked him, did something happen? He said, no, I'm just not feeling well. And he said he hadn't been feeling well for a couple weeks, and it was when there was a really bad flu going around. And so I said, well, maybe you have the flu. I don't think that would make your stomach hurt now. And we kind of kept an eye on him for a little while, and his stomach pain started to worsen, but it still wasn't that bad. And usually internal bleeding is extremely painful. But finally, I just figured he was getting worse and he needed to go to the hospital. So I sent him to the hospital, and we found out later that day that he had ruptured his spleen. And my immediate first thought was, oh my gosh, he didn't have the flu, he had mono. So, these symptoms are somewhat similar to flu-like symptoms as well. So he'd had mono, he didn't know it, and he was playing with an enlarged spleen. They saw in the video of that game later in the day that he had kind of laid out and fallen on the ground on his stomach, and he'd ruptured his spleen just from doing that. We are going to talk about 2 different kinds of anemia as well. These are illnesses that are somewhat common in general in the population, but definitely with athletes as well. Our first type we're going to talk about is iron deficiency anemia. This is prevalent in menstruating women in general and can happen in males aged 7 to 14. Three things occur with anemia. Either the person can have small erythrocytes, which are red blood cells. They could have a decreased amount of hemoglobin, which is a chemical in the body that helps with oxygen transport system. And they could have, or they could have a low ferritin concentration, and that's another chemical that helps with oxygen transport. People can have a loss of blood through the gastrointestinal system in runners, so that can also cause a loss of iron. Menstruation accounts for most of the iron loss in women, though, and vegetarian athletes may be deficient in intake relative to loss. Our signs of the condition here would be for first stage deficiency, they'll have some decline in performance. If they are getting a little worse, they could feel burning in their thighs and nausea from becoming anaerobic too quickly, so they just don't have the oxygen carrying capacity to keep up with their aerobic system when it comes to aerobic exercise. Care here would be to eat a proper diet, including more red meat or dark poultry. Avoid coffee and tea because that can hamper iron absorption. The athlete could also consume vitamin C, which enhances iron absorption, and take iron supplements, but that depends on the degree of anemia. So these pictures down here in the corner, this would be like a normal blood smear for someone who did not have anemia, and this might be what it would look like if somebody was anemic and had less red blood cells than they should. Sickle cell anemia is a different type of anemia. Sickle cell is hereditary, is something people are born with. It's a hereditary hemolytic anemia. So basically, instead of being nice round donuts like this, the individual's red blood cells, some of them will be sickled or crescent shaped. So they'll be more like a little crescent moon here. And that's caused by the body producing a regular hemoglobin. Those sickled cells, or the crescent-shaped cells, have less ability to carry oxygen, limited availability to pass through blood vessels, and they can cause clustering and clogging of vessels, which can cause a person to have what we call a thrombus or a blood clot. So part of the reason is that our blood cells are shaped the way they are for a reason, and they're meant to be primarily uniform so that they can all fit through the superhighway of our blood vessels. So if we had a freeway full of Toyota Priuses and they were all the exact same size and they were all driving down the freeway, things will move a lot smoother than if all of a sudden we have a semi try to merge onto the freeway, right? So it's kind of the same idea with the sickled cells. There's a semi that's trying to move onto the freeway in the middle of the Priuses, and it's going to clog up traffic. Signs of the condition are fever, pallor, or looking white or pale, muscle weakness, and pain in the limbs, especially the legs. The person could have pain in their upper right quadrant, also indicating a possible splenic infarction or spleen damage. Again, the spleen has a lot to do with red blood cell production. The person could have headaches and convulsions also. So this could be a medical emergency. Care here would be to provide anticoagulants and analgesics for pain. If we think somebody's having a sickling event, we really should call 911. People who have sickle cell anemia should not do fitness testing or repetitive sprinting. Any kind of repetitive anaerobic work or repetitive fitness testing could increase the risk of a sickling episode. So these individuals are usually pretty okay with doing long distance type activities, but not repetitive sprints. Another type of serious condition that people can have is diabetes mellitus. We have two common types of diabetes. We have type 1, which is insulin-dependent diabetes, and type 2, which is non-insulin dependent diabetes. We used to call these, type 1 diabetes childhood diabetes and type 2 diabetes adult onset, but we don't call them that anymore because there's so many more kids with obesity and health issues that get type 2 diabetes that it's not really appropriate to call it adult onset anymore. The cause of the condition is a result of an interaction between physical and environmental factors, and it can involve a complete or partial decrease in insulin secretion. Type 1 diabetes is congenital. It's the way somebody's born. They're going to get it if that's how they were born. Most people with type 1 diabetes are diagnosed at a very young age, sometimes as young as 3 or 4. I did have one student athlete who was not diagnosed until he was 19, but that doesn't usually happen. With type 2 diabetes, people can be diagnosed at almost any age, but again, it's more common in middle age or older folks. And with type 1 diabetes, generally speaking, the individuals are not making their own insulin. With type 2 diabetes, the individuals can be making their own insulin, but a lot of times the cells that are supposed to take up the insulin are supposed to use the insulin to help bring sugars into the cell. The cells become not sensitive to the insulin, and so even though the body is still making insulin, it makes it so that it's not working as well. So sometimes it's a specific decrease in the insulin secretion, and sometimes it's more of an issue with being able to even use the insulin that is there in the first place. We have a couple of different conditions that can happen when somebody has diabetes. Our first condition we're going to discuss is insulin shock. This occurs when the body has too much insulin and too little blood sugar. So if someone's taken their insulin and then forgotten to eat, or maybe they took their insulin and they ate, but then they worked out harder than they meant to, this could happen. Our signs and symptoms would be tingling in the mouth, hands, or other parts of the body, physical weakness, headaches, and abdominal pain. A person could have normal or shallow respiration, a rapid heart rate, tremor, so shaking, along with irritability and drowsiness. Care here would be to adhere to a carefully planned diet, including snacks before exercise. For most individuals, blood sugar will decrease with exercise, but occasionally it can increase especially if somebody's diabetes is not managed well. I had a diabetic rugby player on team at UCSD for several years, and that was when they were only practicing twice a week and playing games once a week, and he didn't work out at all outside of that. He was fairly lean. He was actually a pretty small guy, but because he was working out in heavy doses but not keeping a regular routine, it made it a lot harder for him to manage his diet appropriately, and so he had a couple of issues with diabetic emergencies, and he'd actually become unconscious a couple times, not with me, but in general, and so he became less and less concerned, unfortunately, about what was going on, and he was only in his mid-20s, so hopefully he eventually ended up becoming more responsible with his diabetes, but it can be really difficult, especially when you're in your early to mid-20s or teens, to have to be dealing with being that careful. Basically, to figure out if somebody is going through insulin shock, we'll have to determine what their food and insulin intake is during questioning. Generally speaking, if we have any indication that somebody might have too much insulin in their system, we'll give them some form of sugar as long as they're conscious and able to swallow. So something like orange juice, Gatorade, soda, candy would be fine. Anything that has sugar in it. Generally speaking, it's fine to give sugar even if you don't know what their insulin number is or their blood sugar number is, because if their blood sugar is high and you give them some orange juice, you're not going to make them sick, and you're not going to make their blood sugar high enough to make them significantly sicker. But if they are having high insulin and you give them some orange juice, you'll essentially take care of the problem. So giving sugar is always fine as long as they're conscious and able to swallow. Another type of diabetic emergency is known as diabetic coma, and that's what happens when someone has too much sugar and not enough insulin. So this can cause a loss of sodium, potassium, and ketone bodies through excessive urination. So this is also known as ketoacidosis. In recent years, ketoacidosis has not been seen as a bad thing, but when I was growing up, if somebody went into ketoacidosis, they went to the hospital because it's not the way your body is supposed to be functioning. Our signs and symptoms would be diabetic coma would be labored breathing, fruity smelling breath due to production of acetone from the ketoacidosis. The person can have nausea, vomiting, thirst, dry mucous membranes, flushed skin, mental confusion, or unconsciousness followed by coma. When I was in my EMT class, one of our instructors told a story about someone that he thought was actually on PCP because he was so mentally confused and agitated, and it turns out he actually was just having a diabetic emergency. So that people can have a lot of, it seems like almost even psychological changes with diabetic emergencies as well. Care here would be early detection. Knowing what's going on is critical because this is a life-threatening condition. If somebody is conscious and able to give themselves insulin, then we'll ask them to do that if we think or know they have too much sugar. Again, we need to be a little careful because giving too much insulin could also land them in the ICU. So ideally, we would try to get them to check their own blood sugar. Unless you are trained to do so, you should not be injecting somebody with insulin. That should be their job. Next, we'll discuss epilepsy. So epilepsy in and of itself isn't a disease. It's a recurrent neurological disorder that's characterized by periods of altered consciousness, motor activity, sensory phenomena, or inappropriate behavior. So commonly what we'll see is somebody who is having a seizure, so that's the odd motor activity. So usually those people will go between a clonic and tonic seizure, so they'll go back and forth between being curled up and extended. Sometimes they can call out or make noises. A lot of times people will know they're about to have a seizure because they start to get sensory phenomena, and they'll start to get themselves safer, or they'll move away or try to maybe even sit down or lay down on the ground. But when somebody's having a seizure, they don't know what's going on. They can't communicate with another person. Again, this isn't a disease, it's a symptom manifested by a large number of underlying disorders. So somebody could have seizure disorder just because. Somebody could have seizure disorder because of a traumatic brain injury or a systemic illness like multiple sclerosis or something like that. But there could be other causes as well. So our cause of epilepsy is an abnormal cerebral neuron discharge. Sometimes there's a genetic predisposition for this, sometimes not. Again, this could be caused by a brain injury or altered brain metabolism from a systemic condition. Signs of the condition would be periods of altered consciousness, motor activity, sensory phenomena, or inappropriate behavior. We do want to time someone when we know they're having a seizure, because we want to have an idea of how bad it is. So seizures can last from 5 to 15 seconds. That would make it considered a petit mal seizure, or they can be longer, which would be considered a grand mal seizure. These can include unconsciousness and uncontrolled tonic-clonic muscle contractions. Some more information on seizures. Individuals who experience daily or weekly seizures should be prohibited from participating in collision sports until their seizures are under control. A blow resulting in unconsciousness could result in serious injury. The other thing is that if they start to have a seizure, they won't be able to protect themselves on the field. Another type of athlete who I would be concerned about having uncontrolled seizures with participation would be a water polo athlete or a swimmer, because they could drown if they start having a seizure in the middle of the pool. We also, they're also going to be careful with activities involving changes in pressure, like scuba diving or something like that. Epilepsy can be managed with medication. People don't always love taking the medication because it does make you really drowsy. Athletes who are having a seizure may experience undesirable side effects that, as a caregiver or somebody who is working with somebody who has epilepsy, should be aware, such as incontinence. So it's not uncommon for somebody to urinate themselves or defecate themselves when they're having a seizure. If somebody's starting to have a seizure, if they start to act weird and you know they have a seizure disorder, we'll have them sit or lie down on the ground. And if somebody's starting to have a seizure when they're standing or sitting up in a chair, we'll try to help cushion their fall, but we don't try to restrict the person. We try to keep them away from surrounding surrounding objects that could cause injury. And we could loosen restrictive clothing. So if they're wearing like a football helmet, we would undo the chin strap, say for instance. Or if they're wearing a tie, we would loosen that. We don't want to force anything between the athlete's teeth. The last athlete that I had that had a seizure was the one that had the brain bleed, and he started to seize, and he had his mouth guard in, and he was having a seizure, and he was clenching under his mouth guard. And one of the people who was helping to manage the situation was a recovery nurse, and I think she's an ICU nurse or a recovery nurse, and she was trying to stick her hand in his mouth to take out the mouth guard, and I was like, don't, he's going to bite your finger off. So if somebody already has something in their mouth like a mouth guard, don't remove it unless they're choking on it, because they're biting down. They can't help it. And to be completely honest, the mouth guard is probably protective as far as their teeth are concerned, but definitely do not remove a mouth guard if they're not choking on it. We do want to call for an ambulance if it's the athlete's first seizure, if they're pregnant, or if they have repeated seizures. If you don't know if it's somebody's first seizure, just call 911. Another condition that we should be aware of, because it's common in college and high school age individuals, is meningitis. The cause of this condition would be an inflammation of the meninges surrounding the spinal cord and brain. So, for example, the dura mater, remember the dura mater, the arachnoid mater, and the pia mater. Those meninges surround the brain as well as the spinal cord, and they can become inflamed or infected. So meningitis can be caused by an infection brought on by a meningococcus bacteria or a virus. Signs and symptoms here would be a high fever, a stiff neck, an intense headache, and sensitivity to light and sound. When my husband is talking to somebody in the emergency room, trying to determine whether or not they have meningitis, he'll ask them, do you have the worst headache of your life? And if they say yes, then he'll be more likely to consider meningitis. As the person gets sicker, that they can progress to vomiting, convulsions, and a coma if they're not treated appropriately. Care here would be a spinal tap to determine whether or not they actually have meningitis. So this is a spinal tap where a clinician will insert a needle into the spine near the spinal cord to draw some of the cerebral spinal fluid off of the meninges to try to figure out if there's any bacteria or white blood cells. If there are no bacteria but white blood cells are present, then that would be an indication that the person may have viral meningitis. If bacteria is found, though, the person will be put in isolation for 24 hours because bacterial meningitis is very contagious, and antibiotics need to be administered immediately, likely IV antibiotics. Somebody with meningitis will be monitored closely in an intensive care unit. This is a big reason why it's a bad idea to share water bottles in addition to mono. But again, this is just due to the chance of transmitting meningitis because it is very contagious if it's bacterial meningitis, and people, even high school age kids, can die from bacterial meningitis if they're not treated very quickly. Next, we'll talk about hypertension. So hypertension is high blood pressure. We've already talked about high blood pressure a little bit, and you guys have learned how to take blood pressure already. But as far as hypertension, I wanted to go into a little bit more depth as far as what it means and why it's not good for you. So our upper range of normal blood pressure is 120/80. Our risk of heart disease or stroke begins to rise at pressures over 115/75. Prehypertension is considered 120/139/80/89. Stage 1 hypertension is 140/159/90/99. And stage 2 hypertension is at or greater than 160/100 millimeters of mercury. The cause of high blood pressure is most of the time, in fact 90% of the time, there's no reason, it just happens. The person could have a genetic predisposition, or they could have stress or something like that, or it could just be the way they are. Secondary hypertension can be caused by kidney disorders, overactive adrenal glands, a hormone-producing tumor, narrowing of the aorta, pregnancy, and/or medications. One time I accidentally took a 24-hour Sudafed, and I will never make that mistake again because my blood pressure for me went through the roof. It was something like 130/90, and I felt like I was about to die because mine's usually really low. Long-term cases of hypertension increase chances of mortality and morbidity due to putting the person at a higher risk for coronary artery disease, congestive heart failure, and stroke. I actually do have a patient that I've seen a few times at the physical therapy clinic who's relatively young. I think he's probably in his early to mid 40s, and he had congenital hypertension. He's had it for a while, and it wasn't really that well controlled, and he actually had a stroke, and now he can't work anymore. He was a nurse, and he can't do a lot of things for himself that he normally would have been able to do, and he's pretty young still, and it's just because he wasn't well controlled with his hypertension. Signs and symptoms of hypertension would be primary hypertension is usually asymptomatic until the person has complications. So, a lot of times people don't even realize that their blood pressure is high. I had a rugby player for years who would come in, and when he would come back from summer, we would check him, and his blood pressure would be 170/110, and he had no idea. He hadn't been checking it, he hadn't been taking his medication, but he had a strong familial history and personal history of high blood pressure, and high cholesterol. And if you were to look at him, he looked like he was an extremely fit African American athlete. And it's just with certain ethnicities, with certain backgrounds, with certain family histories, people are going to be more likely to have hypertension even at younger ages. Other signs and symptoms are that hypertension could cause dizziness, a flushed appearance, headache, fatigue, epistaxis or nosebleed, and nervousness. But again, that's going to be more commonly when somebody's not used to their blood pressure being high. Care here would be medication is not recommended for those with prehypertension unless other conditions are present. So if somebody is in the lower ranges of being on the higher, a little bit above normal, then we wouldn't recommend medication. A lot of times lifestyle changes may be necessary, so participating in regular exercise, eating a good diet, possibly weight loss if the person needs it. If they smoke, they should quit, and we'd encourage them to decrease alcohol consumption. I was working at a high school about 10 years ago, and I was going through the student athletes physical forums, and I found one kid whose blood pressure, I believe, was like 138/90 or something to that effect. And I brought him in, and he was 15. He was one of the football players. And I brought him in, talked to him, and just said, hey, look, I noticed your blood pressure was high. I'd like to check it every once in a while just to make sure it's staying normal. He said, oh yeah, I actually take blood pressure medication for that. Both my parents have high blood pressure as well. He was also African American and looked like a very conditioned athlete. And I started talking to him a little bit about diet, and he said that I normally eat whatever everybody else eats at lunch. I eat fries or chili fries. I said, well, there are other options in the lunchroom, and I gave him a menu that I'd gotten from the cafeteria, and I said, this food is healthier than eating fries for lunch. And it was something like Chef Boyardee with a salad or something. It wasn't like vastly healthier, but it was better than fries. And he said, oh, okay, that's interesting. Thanks for sharing that information and whatever else. And I thought for sure that there's no way this kid's going to do anything with this. And so about 2 weeks or a month later, I had him come back in and check in with me. And at that point, I think he was playing basketball. And I took his blood pressure, and it was almost normal. I think it was like 125/85 or something to that effect, or maybe in the low 80s. And I was like, what did you do? What happened? Are you still taking your medication? Did you change medications? He said, no, I just started eating the healthier lunch. And, and he started to make better dietary choices and eat less sodium, and that helped. But, he was actually able to get off his medication at 15 with just dietary changes. He was already exercising. He was already playing 3 sports. And all he had to do was change his diet. He just had to stop eating fries for lunch. And he was able to control his hypertension on his own. At 15, he learned how to take care of himself. It was incredible. His parents were not particularly involved with him. In fact, one day I saw his mom at a basketball game, and I said, oh my gosh, you're so-and-so's mom. Isn't it exciting that he's not taking his blood pressure medication anymore? And she goes, oh, he hadn't been taking that in a while anyways. Like, she had no idea. I don't know how she didn't know, but she didn't even know he had still been taking his medication. So again, for those who have stage 1 or stage 2 hypertension, they should be on medication in addition to making lifestyle changes listed above. But if they're doing a really good job with their lifestyle maintenance, they may be able to reduce or eliminate their medications possibly. Another condition that it's important to be aware of, especially when you're working with younger populations, is testicular cancer. This is the most common cancer in males ages 15 to 34 years old. And it is often overlooked, so it's important to make sure that people are aware of it and they're they're screening themselves. The cause of testicular cancer is not known, but it typically only affects one testicle. Potential risk factors could include an undescended testicle, abnormal testicular development, low levels of male hormones like testosterone, sterility, previous testicular cancer, and a family history of testicular cancer. Signs and symptoms here. Another condition that's important to be aware of, because it does affect younger men especially, would be testicular cancer. This is our most common cancer in males 15 to 34. The cause is not known, but it typically only affects one testicle. Potential risk factors include an undescended testicle, abnormal testicular development, low levels of male hormones, sterility, previous testicular cancer, family history of testicular cancer, and signs and symptoms would be pain and discomfort in the testicle or scrotum, a lump or an enlarged testicle, a swollen or collection of fluid in the scrotum, and a feeling of heaviness in the scrotum. I think that's kind of a really strong sign of testicular cancer, is that feeling of heaviness. The person can have a dull ache in their groin or abdomen, unexplained fatigue, or enlargement of one breast. So technically men do have breast tissue, so with the hormonal changes that can happen with testicular cancer, one of their breasts can become enlarged. Care here would be really regular self-exams, or first and foremost, to make sure that we can, or that the individual can identify growth early. But testicular cancer is really highly treatable if it's diagnosed early. There are several different options for treatment, including surgery, chemotherapy, and radiation. The year before I started working at UCSD, one of the sports club's athletes actually passed away from testicular cancer. I believe he was 19 or 20. So just because sometimes even if it is caught relatively early, it doesn't always end up well. But it is highly survivable if it's caught and treated early. Next, we'll talk about breast cancer. This is the most common cancer in women, and it can occur at any age after puberty. A family history of breast cancer is a major risk here, and hormonal influences play a significant role in the development of breast cancer. So especially if somebody has an estrogen dependent breast cancer. Breast cancer often metastasizes or spreads to lymph nodes, the liver, the brain, and the bones. Signs and symptoms of breast cancer would be in the early stages, the person won't have any signs and symptoms, and it's not painful. So unless somebody is doing regular self-exams, they don't always catch it. Often when the person does have signs and symptoms, the first thing they'll notice is a lump in the breast or armpit, or they'll have breast cancer, a lump identified on a mammogram before symptoms are noticed. I believe a mammogram can pick up a lump the size of a pea or something like that, or I think it's a grain of sand, and self-check can only identify something that's as small as a pea or something. So mammograms are a lot more accurate than a self-check. Care here would be self-exams should be performed frequently, and any irregularities should be assessed by a doctor. Just because somebody has a lump in their breast or a lump in their testicle doesn't mean that they have cancer. It can be any number of things. Commonly, the lump could also be a cyst, so or something else like that. So just because somebody has a lump doesn't mean you should freak out about it. but a doctor should check it. A doctor can examine any irregularities with an ultrasound, a mammogram, and or a biopsy. Usually surgery is the primary treatment for breast cancer, so removal of the breast tissue and or any lymph nodes that could be affected. And then additional treatment would involve radiation or possibly hormonal or chemotherapy, depending on the type of cancer that is found. Breast cancer is now highly survivable. In the 80s, it was basically a death sentence, though. Another thing that can come up with women's health that's important to talk about is menstrual cycle irregularities. And we care about these things because the menstrual cycle is regulated by hormones. If a woman is training a lot, that can change her hormone levels, which can change her menstrual cycle, which can change her bone density. So that can predispose that woman to fracture or stress fracture. The other thing that the menstrual cycle will tell us is it gives us a really good idea of the person's overall health. If a woman has a very regular menstrual cycle, that's telling us that her body is healthy enough to be producing hormones regularly. A lot of times if somebody becomes unhealthy, one of the first things that happens is that their menstrual cycle changes because our bodies are very sensitive to changes in health, and our hormones react very quickly to that. Another thing that can change menstrual cycles is strenuous training. So that's another thing too, is if somebody's starting to have really big changes in their menstrual cycle, that can be an indication that they may be training a little too hard. A normal menstrual cycle is anywhere from 25 to 38 days long as far as the first day of bleeding to the next first day of bleeding. That doesn't mean that a person has to be exactly 28 days every month to be regular. That means that they could have a 27-day cycle one month and a 35-day cycle the next month, and they're still considered normal. Amenorrhea is what we call an absence of menses, so that's when somebody does not have their period anymore, and there could be any number of reasons for that. Oftentimes that's when somebody has thrown their hormonal cycle so out of whack that they're no longer menstruating. This is common with people who have disordered eating patterns. Oligomenorrhea would be diminished flow, and that refers to somebody who's having fewer than 3 to 6 cycles per year. So they're only having their period every 2 to 4 months. And again, this is, sometimes if somebody's having this situation, it could be normal for them, or it could be an indication that something's wrong. I had an athlete once report this on her health history questions, and I ended up talking to her about it, and it turns out that she was on a very bizarre diet where she only ate fruits and vegetables. I called her a fruitarian, actually, because she would only eat fruit all day until dinner time, and then she'd make a gigantic pot of spinach and tomatoes, and that's what she'd have for dinner, and that's it. So basically her diet was throwing off her hormone levels. Surprisingly, she actually had her DEXA scan showed that her bone density was fine though, which was really weird. As far as dysmenorrhea, that means somebody's having painful menses, and most commonly people or women kind of either have that or they don't. It's not something that tends to fluctuate greatly between cycles, and it's not necessarily something that's caused by overtraining or something that somebody's doing to themselves as far as their hormone levels. Menorrhagia is excessive menstruation, and again, sometimes that's just how somebody's cycle is, unfortunately. Most of the time it's not that bad, but occasionally sometimes people have such bad periods that they have to be hospitalized for blood transfusions. Polymenorrhea would be an abnormally frequent menstruation, so more frequent than every 25 days. The polymenorrhea, oligomenorrhea, and amenorrhea, those things are more common when women are first starting to have their period. Whenever that is in that 12 to 14-year-old range is fairly common. And then also when they're getting closer to menopause, they'll also start to have some changes in their menstrual cycle as well. So those types of changes are relatively normal. If somebody's in their 20s or 30s and they're having big changes in their menstrual cycle, it's probably something that they're doing either diet-wise or training-wise that's causing that. People can have irregular periods, so less than 25 days or longer than 38 days as well. Or they could have any combination of any of those conditions, possibly. So we did already talk about the female athlete triad during a nutrition lecture, but I wanted to touch on it again. Again, this is a relationship between disordered eating patterns, amenorrhea, and osteoporosis. Disordered eating will have a big effect on the hormone levels in the body, which can cause amenorrhea, and then that amenorrhea, or the fluctuation in hormones really more so, can cause osteoporosis, which can lead to fracture. This often happens when somebody is driven to meet standards of a sport or meet a specific athletic image to attain goals, and that's possible to cause disordered eating patterns. Our signs and symptoms would be some type of disordered eating, either bulimia or anorexia athletica. The person could develop osteoporosis, which is defined as premature bone loss, and either in younger women or in older women can get osteoporosis as well. And that causes inadequate bone development or bone healing. Care here would be prevention, identifying somebody who has this condition and educating them and making sure that they're getting proper treatment. And last but not least, we are going to talk about exercise during pregnancy. Physical activity and or competition during pregnancy can be engaged in up to the 3rd month unless there are any complications present. And that's with non-collision sports. So we shouldn't have women playing rugby when they know that they're pregnant, although it does happen sometimes. The reason for the 3rd month being the cutoff is because up until that point, the fetus and the embryo are below the pubic bone, so the baby hasn't gotten big enough to be peeking out above the pubic bone, so there's a lot more protection for the baby in that situation. Also, you can have some fatigue, but your weight hasn't changed a lot, so your center of gravity hasn't changed as much. The joints haven't spread as much. So there's lots of different reasons why the first trimester is less concerning as far as physical activity. Some women may even be able to continue to compete up through the 7th month of pregnancy. Again, that would be non-contact sports only, so no soccer after 3 months preferably. There was a woman who competed in the last Olympics who was, I think she was a sprinter, or she may have been a middle distance runner, who actually qualified Olympic trials when she was 8 months pregnant with her daughter. As a sprinter, I don't even know. I can barely walk right now, and it's a lot. I don't know how she did that, but she was conditioned for it. She was well trained for it. Pregnancy can have an impact on performance. The body will fatigue more quickly than normal due to the energy being directed to the growing fetus. Hormonal changes can also increase risk of soft tissue injuries. With my pregnancies, I had a lot of joint spreading in my pelvis, and so it was actually painful to even walk a lot or stand a lot, let alone try to run. And also the growing belly can cause a loss of balance, so it may become more dangerous for the person to be running or riding a bike. There is no indication that exercise is inherently harmful to fetal growth patterns unless somebody is, over-exercising and not adequately taking in calories or hydrating. but extreme exercise could result in a low birth weight. But that's somebody who's, again, exercising to extremes. Pregnant women should avoid activities that involve severe body contact, jarring, or falls. So they should avoid high-level soccer after the 3rd month, rugby at any point during pregnancy, equestrian sports, and or basketball after the 3rd month. And that is the end of our medical conditions lecture.